Kia ora tātou. I'm here just representing the Fab Four from Hawke's Bay, who are Kerry, Andrea, Sally, who's unwell and couldn't be here today, and myself. So in Hawke's Bay, we're concentrating on reducing constipation in the orthopaedic ward. And our global trigger tool had actually identified that we had a problem, and it was actually particularly in orthopaedics. Now, remember, I'm allowed to make a mistake. In Hawke's Bay, we don't have a bowel chart. We don't have any particular place where we document bowel activity, and we don't have anything on the early warning scale charting either. When we did our initial baseline, we discovered that 42% of our patients didn't have any record at all about their bowel activities. So we were unable to actually determine what our baseline constipation rate was. Where there was recording, it was quite variable, and where it was recorded, it was quite variable. So it was consistently inconsistent. So our change idea was to introduce a stamp, a self-inking stamp, and in a five-bedded care centre, and the idea was it would record it every shift. Rather than once a day, if everyone had it their responsibility every shift, so at least it would be then at least once a day. And the stamp is simply placed in the margin of the assessment and progress notes, so it's very, very visible. We had one or two unexpected things. We asked for the actual date of when the last bowel motion was, and some of the nurses preferred just to put day 1, day 2, day 3, which is actually very difficult because you don't know when day 1 actually started or day 0 was. That was resolved with very brief education because we were confined to one care station. And on a few occasions the stamp wasn't used because it had been nicked by one of the other care stations. We found that there's actually been a lot of leakage of our stamp. Patients transferred to other wards have shown where the stamp is available, and other wards are actually now wanting to get stamps as well. So our data here is we've got two lines. The light blue is the actual recording of when the bowels are open, and then the darker blue is the number of days since last opened. So we've got the introduction of the stamp around here. You notice that the scale is actually not linear because you've got the usual process of procuring said stamp and who's going to pay and all that sort of exciting stuff. But so we introduced the stamp here, and you can see we've actually got 100% compliance, but we've only got two weeks of data so far. But encouraging. So the bowel stamp has increased the recording activity. It's more consistent where and what has been recorded, and it's a breeze for the auditing. It's much more distinct. If it sits there, it stands out, you can easily see where it's been done and when it hasn't been done. So our next phase is to adopt and implement the stamp across all care centres, which we've actually just done. As I said, we've had leakage. Other wards are actually wanting to use the stamp, and we're now in the process of re-establishing our baseline to actually see what the constipation rate is. However, it looks like we may not have a problem. Again, we've only got 14 patients, but only one of those patients has got constipation. Our thinking is we've had a bit of the Hawthorne effect because we've got the bowel nurse coming around and actually recording and auditing. We've also got the ERAS system going on, and that involves bowel management as well. And we think all the other activity that's gone around has elevated the bowels and the importance of it. So we're going to collect a bit more data and then decide what we're going to do. It may be that we actually have to move from going from the inpatient to the outpatient. Because we've got a couple of patient stories over there where the problem actually becomes more evident when the patient's discharged. It's not a problem when they're inpatient. So that's us.
Okay, so I'm just going to talk a little bit about learning through PDSAs. We've done a number of PDSAs, but our PDSAs are really about collecting data and looking at where we want to focus our attention. What worked? So our problem statement, our display's over there, so if you wanted to have a look, you'll see more about how we've come to focus on what we are, which is nausea and vomiting. But 2.3% of patients in orthopaedics that receive opiates have a documented issue of nausea and vomiting. And we got that from our CHADx data. And we also know that there is an issue with constipation, which is about the same rate. So we thought that this was a really tangible sort of place to start, and that we'd be able to monitor and have something. So we've looked at 10 months of CHADx data, and it shows that our highest peak was 3.1%, and at our lowest we're sort of sitting just under 1%. So it doesn't seem a lot of patients going through each month, but it's a really good sort of baseline and starting point. But where we sort of got to was establishing the team, and I think that's actually most important. So after learning session 1, we went away and we sort of started to talk to a lot more people, and it became really evident that people were questioning, why is it as low as 2.3%? In orthopaedics, we think it's a lot higher. So talking to staff and getting the anecdote information. So we needed to start to look and say, well, is our baseline an okay baseline, or do we actually need to look at it differently? We invited anaesthetics on board. They had quite a high level of interest, and their literature would indicate that 20 to 30% of patients have an issue with nausea and vomiting in that perioperative and post-operative period. So we needed to then look at and validate, where are we looking? Is our CHADx data our right baseline, or do we need to look at it differently? So we've spent a lot of time also looking at our coding process. What we have sort of found is that, because what we want to know is our CHADx data a reliable baseline? We still believe that it is. And I think key for us is to know if we make a change and our CHADx rates change, so if they increase, is it that we've fixed the coding issues? Is it that we've increased staff awareness so we're actually getting the link documented in the record? Because of course coding's only reliable if staff are documenting it in the clinical record. So though we're sort of exploring those things, but at the same time we're continuing to sort of look at our project moving forward, because I think the problem with, certainly from my perspective, the problem with sort of holding on and trying to focus on your baseline alone can stop you actually moving on with your project. So we're sort of doing two things in tandem. So we did need to look at what was actually happening in the orthopaedic wards, and that was at the point where John and Prem were down, and so we took the opportunity to meet with the charge nurse managers of the two orthopaedic wards at that particular time. We worked with them and we looked at what data are we going to catch, how do you want your staff to actually record this, what will work for you, and we came up with sort of a manual data collection process. So just looking at the number of patients that had an episode of nausea and vomiting. Again, the tool's over on our display over there. But we had to sort of set some rules, so we're only capturing the patient once in a shift, because some patients can have several episodes. So we worked with the staff in the clinical area to identify how we were going to capture that information. So what were our results? So the elective ward, they pretty much consistently collected the data, and it showed that anecdote would have indicated that Thursday was their worst day, because there's an anaesthetist that doesn't like to prescribe antiemetics. But in fact, Friday on both areas was probably one of the worst days. So that was sort of interesting. The acute ward, they missed 3 days of data collection. And so what we've found, because we've now got another manual data collection process going on, and what we've found is that it's okay for a period, but it's reasonably unreliable if you want to look at it as an ongoing baseline. So from here, we will continue to use our CHADx as a baseline. The key thing for us is, as I said, knowing when we make a change, how does that change influence our baseline, so that we record that particular point. And we are also looking at a second baseline, so we're starting to explore the national minimum data set, and what we want to look at is, with the patients who have an identified issue, through the national minimum data set, are we picking up the same rates? Is our rate sort of more comparable with our anecdote from anaesthetic literature or from our CHADx baseline? So those are the sorts of things that we're continuing to explore. So we have our CHADx baseline. We've nailed that one. We're still looking at, do we have a secondary baseline? But we are continuing on with our project per se to reduce the harm to patients around nausea and vomiting. So that's where we're at the moment. Still work in progress, but yeah, happy to take questions.
Right. So some of you I met in Learning Session 1. Capital Coast, I was involved with two SAC2s and one SAC1 event in 2011, 2012. And the SAC1 event, the patient died as a result of respiratory narcosis linked to Severodol. And so within CCDHB, thanks to the Health Quality Safety Commission and the Improvement Advisor Program, that's why we commenced our opioid journey. And we've made a lot of changes. I've got Janice and Belinda here who have been with me in our MD team from the beginning in terms of patient information that some of you are using, changes to patient-controlled analgesia policy and process, how we chart opioids, particularly PCAs within our hospital. And as a consequence, we haven't had a SAC1 or a SAC2 since as a result of opioid use, which is very pleasing. We have an issue now with fentanyl use, and we really wanted our project to be focused on the use of transdermal fentanyl patches because our palliative care clinical leader was feeling that that was a real risk for us, that a lot of patients had multiple patches, which can be quite dangerous. So I've been asked to share our PDSAs, more to show how you learn and you test and evolve. So our original aim was as a 3DHB, and I do need to mention that I'm from CCDHB, but with us, we are working very closely with our sub-regional partners, which is Hutt Valley DHB and Wairarapa DHB. So because we had an existing group, we had staff join our group from Hutt and Wairarapa. And so our initial aim was, as a 3DHB, we aimed to, reduce adverse events related to fentanyl in our elderly population by 25%. We wanted to follow the model for improvement, and I really wanted to make sure we were focused on the right area. So we really wanted to sort that out, and I really like this from Albert Einstein. If I had only 1 hour to save the world, I would spend 55 minutes defining the problem and only 5 minutes finding the solution. And that's really as a result of our initial project. We were trying to solve world peace at the very beginning, and for this project we really wanted to make it quite defined and achievable. So we started our PDSA journey. Our first PDSA, the objective was to establish the patient group that used fentanyl patches. And that involved a lot of work with Janice, our pharmacist at our DHB, and also the pharmacy teams at Hutt and Wairarapa. What we found is we could identify 3 focus wards that we could focus our activity, obviously. But in Hutt Valley there wasn't high usage, and in the Wairarapa DHB the fentanyl patches were mainly prescribed by the doctors. So because this is an inpatient harm project, that was a problem for us. We weren't going to sort of stop there. We wanted to establish actual patient harm through the use of fentanyl patches, so we trawled through our reportable events. And what we learnt in our original project was, as you know, reportable events are very much subject to people actually lodging them, so it's not the most, it's very person dependent, shall we say. So out of the 25 NHIs we'd found through our original trawl of fentanyl patch usage, we'd only found 1 reportable event from that, and that was only in our hospital. So we went to our global trigger tool data to see what that had to show us. Again, only 1 event. So we really needed, as we've talked about, some measures to see whether we could make an improvement, and it wasn't looking particularly good. So we had to really sit back and think, well, is transdermal fentanyl patches what we can really focus on? And we discussed it with the team, and we had to really let it go. We will go back and look at it, but it's not really suitable for this project. So we went back to global trigger tool and adverse drug error data, which we only have at CCDHB. Wairarapa and Hutt are looking at introducing that, but they didn't have that data source available to them. And what we found out of all of the actual opioid harms, constipation again was our biggest problem. So, as a result of the various capacities of the 3DHBs at the moment, we've established that CCDHB will forge ahead just in the interim. And so from those opioid harms that we found, we were able to identify that our 6 North Orthopaedic Surgical Ward is our greatest problem area. And on our storyboard chart, you'll see a Pareto chart that demonstrates that. So yes, that's our Pareto chart. And so our revised aim for our DHB is to reduce constipation or harm associated with opioid use by 25% by June. And that's it.